Thank you for joining us and welcome to the Community Wellness Roundtable, brought to you by the Community Engagement Core of the Howard University Research Centers in Minority Institutions program. This discussion is being recorded and will be posted on our social media channels. Good evening, everybody. I'm Karen Parker, Project Coordinator with the Research Centers in Minority Institutions, or RCMI program, at the Howard University College of Medicine. I'm your host for this evening, and I'm joined by my colleague, Ms. Kristen Holmes, and our principal, Dr. Carla Williams. If this is your first time joining us, welcome. And if you are returning, welcome back. Kristen is now going to bring you up to speed on what we do. Kristen, over to you.
Thank you, Karen. Thank you, Karen, and good evening, everyone. My name is Kristen Holmes, and I am the engagement specialist on our team. Our RCMI program focuses on enhancing and developing the necessary research infrastructure that ensures Howard University's ability to contribute to the resolution of diseases that disproportionately affect underserved and minority populations. Our group, the Community Engagement Core's primary goal is to ensure that RCMI-supported research addresses the needs and interests of our local community. To achieve this, we do three things. First, we partner with local community organizations to address health-related concerns. We promote community participation in research in partnership with researchers in study design and execution. And we ensure research findings are shared with relevant communities. That's why tonight's conversation with you is critical to our. Thank you so much for being here.
I appreciate that, Kristen. Thank you. And I'd like to add that another one of the reasons that we hold these roundtable discussions is to bring the research conversation forward in our communities. So we use this image of the 6 R's so that we can highlight the ideas that you see here in the event that you're considering participating in a study. So as you can see, the first R is representation. If you're considering participating in a research study, you want to know if the research includes people like you. The next R is regulation. Are the methods used in the research going to be ethical, and are you protected? The third R is replication. That is, if the study is done somewhere else, is it going to produce the same results? Riger, do the results represent what is really happening within ourselves and within our communities? The R for review is whether other experts will view the study as high quality and significant. And what I mean by other experts is people within the same field of under study. And the last R is relevance. So what, you participate in this research, how are the results going to affect your day to day? Moving forward, we are just going to have a quick note that there is a study that's ongoing here at Howard. It's called the RADX study. I am the project coordinator for that study. It is called Community Conversations About COVID. It's an online study. It's non-invasive. You can fill everything out online, and it's primarily to help us understand what is important about life beyond COVID-19. We've all experienced it in some way. And it's to help researchers like us find the best ways to share information. So if you have been on one of our previous roundtable discussions and you've taken part in this study already, thank you very much. As you can see on the poster, all you need is to complete up to 2 online surveys. So the survey itself is split into 2 parts. The most that you can get is $100, and that is for completing the study, the survey completely. But you can, at any time, decide that you're done, and then we sort of prorate the compensation in that way. So there is going to be a link that is dropped into the chat at the end of our presentation and in the follow-up email that we send in case you are interested in participating in this study. Next slide, please. We're just going to recap very briefly. We are doing part 2 of our presentations on summer skincare and summer hair care. So if you missed it, and it was in May last month, we had Dr. Jeanette Okoye, who I believe has joined us this evening. And this is just a brief recap of what she talked about, but we will drop the link to that recording. It is on our YouTube page. It was an extremely insightful and information-filled presentation. So please do go to our YouTube page for the entire presentation. But just very quickly, Dr. Okoye talked about sun exposure in moderation is good for our physical and mental health. If you have certain conditions or you take certain medications, you need to be more careful with how you're exposing yourself to the sun. So you've got to protect yourself. She recommends that mineral protection of SPF 30 or greater is what you should be using to protect yourselves from sun exposure, as well as hats, protective clothing, and of course, shade. And lastly, well, not lastly, one of the high points that she brought out is that hydration is key. And hydration is not just with water, it is water and electrolytes. So again, I urge you to go to the link in the chat of the YouTube presentation, and you'll learn all about how to best protect your skin this summer and enjoy the summer sun. Next slide, please. So we've moved on to tonight's presentation, which is summer crown care. We have 3 experts, and I'll just introduce them in the upcoming slides. We have joining us this evening, Dr. Chesahna Kindred. She is, as you can see, a volunteer faculty at Howard University College of Medicine in our Department of Dermatology. She currently has a research focus in scalp and body plaque psoriasis and pediatric eczema. She is also the founder and president of the Onyx Medical Society and chair of the National Medical Association Dermatology Division, as well as chair of the African American Community Roundtable Health Committee. Welcome, Dr. Kindred. Joining Dr. Kindred at the roundtable, we have Susan L. Peterkin. She is a cosmetology pioneer. I cannot wait to hear what this lady has to say. She's done so much. As you can see, she is the founder of the Natural Hair Industry Convention. She is a lecturer in a natural hair care course at Montgomery College. And if I'm not mistaken, she designed that course. Is that right, Ms. Peterkin? Yes, she's really a pioneer. She is also the creator of the first natural hair care program at a correctional facility. I think I'll ask you a little bit about that as well. She is also the founder of the first all-natural, that is no extensions, hair salon in the DC metro area. She is also the creator of the first full-service natural hair salon that is located inside of a dermatology practice. She is in practice with Dr. Kindred. Welcome, Ms. Peterkin. As well, we have another expert joining us. We really have a heavy roundtable this evening. Please welcome Dr. Madeliene Gainers. She is a diplomat of the American Board of Dermatology. She completed an International Society of Hair Restoration Surgery Fellowship and a Harvard Skin Disease Research Fellowship. She is a member of the American Hair Loss Council, the American Academy of Dermatology, the International Society of Hair Restoration Surgeons, the National Medical Association, the Jacksonville Dermatology, and the Northeast Florida Medical Society. She is also the founder of her own practice. It's named after herself, Madeliene Gainers, and it is a hair restoration and dermatology practice here in Chevy Chase, Maryland, very close to us in DC. Welcome to all of you. And without further ado, we'll launch into our discussion.
Thank you so much for the introduction. I have to say my esteemed colleague, Dr. Sharif Fry, is actually now the chair for the dermatology section of the NMA. But what we're covering today, we're talking about the top 3 forms of hair loss in Blacks and skin of color. And one is central centrifugal cicatricial alopecia. Clearly, I'll be referring to that as CCCA from here on out. Traction alopecia, and then male or female pattern hair loss. And this is an open discussion. So what's great is there are already some questions that were submitted that were great questions. And we will get your feedback on these questions in the comments. And that is, do you have a hair regimen, a daily care routine? Do you know how to properly moisturize your hair? And do you know how to properly detangle your hair? And what's great is we have Susan Peterkin on here, who she does my hair, even though I embarrass her sometimes. But this, I think, speaks to the great relationship between stylists and dermatologists. And Dr. Gainers, do you have a stylist that goes into your practice? I know you were thinking about incorporating that.
Oh, no, I have from the beginning. That's Evie Johnson. Yes, yes. So she comes in periodically and she'll do her consultations here as well as style the hair and do a consultation from that perspective as well. I think it is essential for our patients to have a great team behind them, not just with the dermatologist, but also the trichologist or stylist.
And so for anyone who is dealing with hair loss or any disorder of the scalp, it really is important that your stylist is connected with the dermatologist, because there's enough of us, particularly in the Maryland area, but elsewhere as well, there's enough of us that we can have your stylists back.
Yes, I agree.
All right. Shall we go to the next slide?
All right, so I guess this is me. All right, so healthy hair practices. I am a big proponent of this, because if you don't have healthy hair practices, just like anything else with in your healthcare, healthy teeth practices, your skin, and of course, scalp is skin. So everything has to be done for you to get the, maximum growth, maximum hair, nice and moisturized, feeling the texture that is supposed to be felt, because I'm not going to say the word soft, because not everybody's texture is soft and supposed to be soft. That's a whole nother subject. But feel the way how your hair is supposed to feel. That comes from your particular genetics, right? DNA, right? So what is your shampoo process? How often do you shampoo? Lately, we have found that that we need to shampoo more often. A majority of the issues that we're having is because our scalp is dirty, but we keep putting more oils and butters and stuff on our scalp, basically clogging up our pores, and sometimes making some of these hair loss issues get worse, right? What is after shampoo conditioning process? I'm going to be talking about that today. Do you really need to condition your hair if you use a moisturizing shampoo? Again, it depends on your particular hair texture, your curls. I know with myself, my hair is so fine and soft. I shampoo my hair twice, and then afterwards I just do like a little bit of leave-in conditioner, because my hair is so soft. It does not need heavy creams and butters, right? And what is your daily routine? There must be a daily hair care routine. You must have something that you do to your hair every day to make sure you understand, because you know your hair better than everybody else, better than the dermatologist, better than the hairstylist, and you need to keep up with your hair, especially if you have hair loss. you should be taking pictures yourself. You know, you shouldn't have to come to the hair salon or the dermatologist for us to tell you, oh, here's a new spot or something. If you're going through hair loss, you need to be proactive about your hair loss so you can inform us, and then we will know where to take it from there, right? Today, we're also going to discuss the detangling process. Unfortunately, usually I have a model or a mannequin head that I work on. And I was going to have my mannequin head, but I've been traveling and doing shows for the past 2 months. And I think I left my mannequin head somewhere. So unfortunate, but I do have our famous, where's it? Peterkin Kindred brush that I'm going to show you.
This brush is the truth.
Tangle process, and you know, discuss tools depending on hair texture and how to detangle. Next.
Dr. Gainers, we need to send you this brush.
I would
We need
love
to.
that.
It's a
Thank
game
you.
changer. Yeah, but she'll go over it. Let me keep my mouth shut about the brush, and let's talk about CCCA. Again,
I'm very
Central
excited
Centrifugal.
about your brush though.
Yes, it's great. So CCCA, let's get started. We can go to the next slide. So CCCA starts in the center of the scalp, hence the term central. It spreads, and that's centrifugal. And stylists have, for decades, have already known about this. They've called it the soft spot, the sweet spot, etc. It was just not really studied until recently. Cicatricial means it's scarring. It creates permanent destruction of the hair follicle. And that's where the game changer is. There are forms of hair loss where it does not destroy the hair follicle, in which case you have a chance for the hair to grow again. But for cicatricial alopecias or scarring hair loss disorders, there's permanent damage. Then alopecia, which just means hair loss. I'm gonna throw this at you, Dr. Gainers. Is alopecia a diagnosis?
No, it's not. Like you
No.
said, it means hair loss. And we often have patients come in and say, I know what I have. I know I have alopecia.
Listen.
You know, and it just means that you have hair loss, and we have to figure out what type of alopecia so that we can figure out the best treatment for you.
There's 15 types. So someone telling me that they know, and I'm sure everyone agrees here, that you've been diagnosed with alopecia. That's like saying you've been diagnosed with a cough. I don't know if it's COVID, lung cancer, acid reflux, heartburn, or what. So we really want a specific diagnosis. And if you've been diagnosed, you don't want to just call it alopecia. And the most common form of hair loss in Blacks is CCCA by far. If you add up all of the forms of hair loss, this is still number one, and it's more than the sum of all the other forms of hair loss. Next slide. So the cause, right? What triggers it? So we now know for sure that there's a strong genetic component to it. This is actually research done by a group of dermatologists and geneticists geneticists were out of Israel, and the dermatologists were multinational. And I'll just give the example of the PADD3 gene. So this gene is responsible for, well, let me back up. Genes encode proteins, and the proteins that make enzymes, the proteins that make reactions happen better or faster are enzymes. This protein that the PADD3 makes is an enzyme that folds and shapes other proteins that make our hair. So kind of a chain reaction there. So in CCCA, there's a defect in this gene, and there's other genes as well. And you have a chain reaction where you now have a defective hair follicle. As far as your body is concerned, if you have a hair follicle, the immune system in the surveillance should recognize that there's a defective hair follicle and destroy it. So once you have a defective hair follicle, you and I are going up against what your body wants to do, which is to make you bald. And that's why we don't have a cure. A cure means we can get to the root of it and fix it. We are doing no gene manipulation on you, right? And we're not getting rid of all of your inflammation. Inflammation is your body's only weapon. That's how your body fights cancers and infections. So we're not doing gene manipulation. We're not getting rid of the body inflammation. So the best we can do is control the disease. And anytime the body is the source of the problem, that means we don't have a cure. Now, I still have hope. I'm gonna keep hope alive. One day we'll have a cure, but until then, the best we can do is control it.
Absolutely.
Dr. Gainers,
And
how do you explain CCCA to your patients? What causes it and such?
yes, absolutely. So similar to what you just said, I just want to piggyback on one thing. I am so glad you brought up that point. I have to tell patients all the time that I have no ability to go in and tweak your genetics, because they often say, well, how long do I have to be on minoxidil? How long do I have to get this? How long do I have? Exactly. I said, as long as you have a tendency to want to thin in this manner, you have to continue on with your treatment. I try to give the analogy of if you had uncontrollable high blood pressure, and despite your best efforts, diet, weight, everything, you have uncontrolled high blood pressure and it runs in your family, and your primary care gives you a medication that works wonders for you. Do you then go and ask, well, how long do I have to take this medicine and what happens if I stop? So even though we're talking about hair, it's very similar. You have to keep up with some kind of maintenance treatment because there is this genetic component.
100% true. All right, we can advance. So this is something that we use. I love to use this lovely patient, and it highlights the beauty of the relationship between stylist and dermatologist. This is a patient of mine that also saw Susan at the time. And this is standard. This is her baseline photo. This is how she looked when she first walked in my door. And what's colored in yellow are areas of hair loss. Like, it's nothing but skin under there. We did a biopsy. We started her on medical treatment. So yellow, I was able to get the computer to generate like the surface area, and that's what you're looking at to really help highlight it. So this is how she walked in my door. Next slide. And in 3 months of medical treatment. So if I turn, the slide off right now, you guys would all say, yes, it works. So medical treatment is a lot. It's injections, it's pills, it's topical, it's shampoo. The difference is this patient also sees Susan. Okay. So any dermatologist would pat me on the back from reducing her area of hair loss from this before to this after. However, with that amount of hair loss in the center, this young woman is still wearing a wig, right? So no matter how much kudos one of my colleagues would offer me, she walked in with a wig and she's walking out with a wig. And this is what I was able to do medically. Now let's fast forward to what Susan was able to do. So let's go to the next slide. What I want you to note is the middle picture and the picture on the right. The patient's wearing the same shirt. This is the same day. She walked in on the page on the left and the center with the wig both days, but Susan then did her hair and she walked out with the wig in her purse. Susan, you want to talk about the technique you used here?
Yes. I love using doing flat twists to camouflage hair loss, and because it's very gentle on the scalp. There's no, as you can see, there's no pulling. I do not use a lot of heavy gels. We have to step away from that when those kind of things when we have hair loss. So I was able to create a style, going, to one side to camouflage the hair loss. This will last her for like about 2 weeks. She ties it up at night. And most important, she can still get to her scalp because the topical that Dr. Kindred gives her, she must apply it. And I always keep that in mind when I'm creating a style for my clients so that they continue. She can still come in and get her injections if she needs to get her injections. So it can be manipulated and then close it back up, so she can leave again with it. So a nice, soft, functional, still feminine hairstyle. And the more the hair grows and the more the hair, gets fuller, then we can create other options with the hairstyle.
So there's two things that we want stylists to do, or for the hairstyle. One, for it to be socially acceptable, right? One that the patient likes. But then two, for it to not be detrimental based on the diagnosis. And patients have to work really hard to find stylists that can meet both of those criteria. Next slide. So the key to CCCA is to treat it as early as possible. Because remember, it permanently destroys the follicles. That's the root to a plant. If you destroy the root, you grow no plant. And while I'm going to talk about a lot of advancements that we have, I still need to treat the CCCA as early as possible. For this patient, maybe we can fill it in a little bit. And the main thing we'll be doing is stopping it from worsening. Any comments about that, Dr. Gainers?
Yes, actually, with the last slide you showed, I love that, because as you know, most of our patients don't even present with just one type of hair loss. It's so common that by the time they come to see us, they're coming with not only their CCCA, but obvious traction alopecia at the frontal scalp as well. Traction alopecia, I think we're going to speak about that a little bit later, but sometimes that's an effort from their stylist trying to conceal the CCCA. So that just reinforces the point that you definitely have to have a great stylist or trichologist that cares about healthy hair growth, along with your dermatologist, to prevent that second type of hair loss, that traction alopecia going along with it. So I love those flat twists. I think that's beautiful.
All right, and next slide. This is important as a form of CCCA where it's not fully blossomed. You just get a zone of abnormally short hairs. That doesn't appear well in a photo because it still looks full. So this was the best photo of a patient I had to kind of emphasize. You can just get a zone of hair, usually in the center, where the hair still grows, but it always breaks off. That is a sign, an early sign of CCCA. And you want to hit it hard, right? I go full throttle when I have that very, very early form where it's just breakage for CCCA, because usually in about 6 to 8 months, it's like this after photo. If you look closely, you can still see she has some hair loss, but it's definitely fuller, and it really changes her whole, she says it changes her life, but at least it changes the options that she has for her hair.
Yes, that's really exciting when you see a patient come in who looks like the slide you just had, because you can see those follicles are still present. They're just not thriving. And you can make such a quick, efficient difference.
Yeah. I want to pause here because we just covered CCCA. That inflammation produces itching, tingling, stinging, soreness, burning, sensations, tenderness, and pain, usually in the center of the scalp. And that may have rung true to quite a few people. So do we have questions about CCCA that we should pause and address?
Yeah, there's a couple in the chat that I saw.
Okay, let's pull it up. All right, let's see. During CCCA treatment, is it recommended that the patient not use color, straightening chemicals, or heat on the hair? Let me see. Susan, let me throw this at you first.
Okay. All right. So from a stylist wellness perspective, if your inflammation is active, like going haywire, it's definitely a no. It must be under control, and the color that you use should be some form of vegan based, something that your stylist knows well. It shouldn't be an over-the-counter color. It should be a color that your stylist should be able to give you some kind of chemicals some kind of reading so that you can see the kind of chemicals that's in there, less of what Dr. Kindred can also talk about certain type of chemicals that should not be used in certain products. As far as straightening chemicals, I don't do that, even though I'm a licensed cosmetologist. And this is my 40th year being a cosmetologist. I think I did chemicals maybe 6 months out of the 40 years. I never liked it, so I don't do it. And I don't recommend straightening chemicals because they're so harsh. And if you have CCCA, it doesn't cause the CCCA, but it can make it worse, right? So that the color we can control, because the color that I use is a vegan base. When you use it, it doesn't even, you don't smell a chemical reaction. And as I said, I make sure if a client walks into the salon for the first time and they say they have CCCA, recommendation from Dr. Kindred and they want color the same day, I usually don't. I usually tell them, I need to get to know you. I need to get to know your scalp. I need to get to know how your CCCA presents itself and what's going on. So I will know how to adjust and what kind of color and when to do color. So you can get it, but you just have to have precautions.
Mhm. That was just excellent. And in my practice, I've definitely seen tremendous improvement in CCCA, or it's easier to improve CCCA when a patient with the relaxer gets rid of the relaxer. But it's like CCCA, that hair just wants to be baby. Now, are there people with relaxers and CCCA and they're doing fine? Yeah, but we're talking about just overall what the trends are that we see. The next question I'm gonna fill to Dr. Gainers. So if treated early, is CCCA able to be arrested?
Absolutely. I see that all of the time at my practice, that we're able to, at the bare minimum, stop the progression. That's always the goal. And then hopefully you also get some hair back, a noticeable amount of regrowth. However, with that being said, I will say we're still learning more and more about CCCA. And it appears to be multifactorial as far as the causes. And some people do seem to have a more severe gene expression. So even if the person presents earlier, it does not mean they're going to have the same outcome as the next patient who presented early. They still may have a more aggressive form and need to do more and still over time thin a bit. But as with most medical conditions, early intervention is always going to be best.
Excellent. Okay, we can advance to the next slide. And now we're going to discuss the most common form of hair loss in the world: male pattern hair loss, female pattern hair loss, androgenetic alopecia, androgenic alopecia. Everything in dermatology actually has about 2 or 3 names. And since this one is so common, I wanted to make sure to include each one. If you look at the photo on the right, it might look to you all that's very similar to the photos of the other patients that I showed with CCCA. So early CCCA, especially if the inflammation is mild, can look just like androgenetic alopecia. And I just want to emphasize, not every Black or brown person with thinning in the center has CCCA, and not everyone has female or male pattern hair loss. So you really want to see a dermatologist and really get a definitive diagnosis. Let's go to the next slide. With androgenetic alopecia, what's happening is your own hormones, particularly testosterone, goes into the scalp to the follicle and miniaturizes the follicle. So just like a plant, if the root is weak, so is the plant. So if the follicle is miniaturized, it grows a miniaturized hair. And that's represented in like the yellow and red streaks. Those are overlying actual hair strands. And you see some really thin, fine hair strands that aren't colored versus the nice, healthy green ones. See how nice and thick those hair strands are? Those are the healthy ones. And as time goes by, more and more follicles really miniaturize. So here we are, the root of the problem. The testosterone, male hormone, is miniaturizing the follicle. We don't have a cure because we're not getting rid of all of your testosterone, right? So this is another case where we have to control the condition. We can't cure it. All right, next slide. So this is one of our patients who had female pattern hair loss. And again, the yellow represents the hair loss. And then this just showed, I think this was about 4 to 6 months of treatment. And I use this because I like to emphasize not every Black woman with thin edges has traction alopecia, or as some people call it, tension alopecia. Sometimes it's androgenetic alopecia, and not every Black person with hair loss has CCCA, even though CCCA is the most common. Anything you want to mention about androgenetic alopecia, Dr. Gainers?
Yeah, so it is the most common type of hair loss. It's particularly common with Caucasian people and Caucasian men. Probably by the age of 70, at least 80% will experience that. And it could be less common depending on, the ethnicity of the person. But certainly I agree with you that you don't want to just make an assumption because you see thinning at the crown. If it is addressed early, androgenetic alopecia actually is really responsive to treatment.
Yes.
It's responsive to minoxidil and PRP and your laser stimulation. So that's just another reason to do not pass go. Get into the dermatologist's office when you have that thing. You can make a huge difference. Yes.
Mm-hmm. All right, next slide. Let's see. I think we had a question on androgenetic alopecia. Let's see. Interesting. Will or can my hair ever be thicker again after 13 years of chemo? Let's see. Did you want to address that, Dr. Gainers? Do you want me to address it?
If you have not had medical treatment, it's definitely worth a try. I definitely think it's worth a try. I would never tell somebody you will not have any regrowth, despite your efforts. Yeah, you should definitely give it a try.
Chemo, hair loss from chemo actually is temporary, right? So 13 years later, you have a small chance of the hair loss being just chemo. What we've definitely seen is that there's often a small underlying smoldering form of hair loss that worsened or was exacerbated after chemo. Unmasked after chemo, in which case you now need to address that original form of hair loss that you're now still dealing with. So will it ever be thicker? First step is get a diagnosis. So see a dermatologist. If you're local to Howard, you have Dr. Gainers, who's right in Chevy Chase. The next question is, does androgenetic alopecia in women happen when they lose estrogen or progesterone at a certain point of maturity? I'm gonna use that, a certain point of maturity, instead of saying as they age. I like that. I used to say as they get wiser, but a certain point of maturity is better. So it can, for some people, it is indeed, it is, a time thing, right? It is an age thing. But if you think about, let's say back in your 20s, right? Let's say in college, you saw some guys where their hair was completely shaven, right? Chances are they already had androgenetic alopecia. It's just socially acceptable for them to cut their hair. So my youngest patients are in high school and they have biopsy proven androgenetic, I mean, they've been tested and I know for sure they have it. So it's not always just an age thing. It's worse as you get older. Dr. Gainers just mentioned a statistic. It's 40 by 40 is one way to remember it. 40% of women have some form of hair loss by the age of 40. And chances are they're referring to androgenetic because not that many Blacks were included in that study. And the numbers go higher and higher as time goes on.
Yeah. So certainly you're gonna see that number increase as a woman, postmenopausal. If you're postmenopausal, you'll see that number increase, and that's led some people to believe that estrogen probably has a stimulatory effect on hair growth. But there's been other studies that, take that into question. But yeah, you certainly will see an increase in the population of people who will suffer with androgenetic alopecia after menopause, probably because of the changes in hormones.
Yeah. So we're going to go to the third practice, the third diagnosis, which is traction alopecia. And if you look on this young lady here, and beautiful, long, luxurious hair, but not according to her because of her hairline. And you see there's 3 rows. There's her new hairline, right, which is right around at the level of her ear. There's a zone of hair loss. And then there's her original hairline. That's the zone of hair that's closer to her eyebrows. So when you see this, it's also called the fringe sign. It's very likely that she's suffering from traction alopecia. And this is caused by tension, right? This is an outside job. This is from hair loss and other forms, which means, yes, there's a cure, right? Avoid hairstyles that create tension on the edges. Let's go to the next slide and then we'll have a discussion about it. Think of it like a tug of war, right? You have your follicle trying to hold on to your hair and your scalp, and then you have your hairstyle, your brush, the ponytail, the braids, the weave, trying to pull the hair out. And over time, you'll win some and you lose some. But if you lose some, it could be permanent. This is a form of hair loss that starts off as temporary, but then as time goes by, it can be permanent. Susan, you want to talk about some of the styles and triggers for traction and how to avoid it?
Yeah, so, I'm just going to put myself out there. because I was usually, I love braids, but usually I would get individual braids that are not too tight, because me personally, I have 2 types of hair loss. I have CCC and I have female pattern baldness. And, Dr. Kindred has been treating me. So I decided, I haven't gotten cornrows in like 10 years, 15 years. I decided it's quick. I'm going to do some cornrows because I'm going on the road for 3 days. I don't want anything to do with hair. And the first day I put it in, I felt it, and I know better. I'm going to say it again. I know better. And I kept it in. And just the week before, I was in Dr. Kindred's office and I got my shots for my information for CCCA. And she walked into the salon and she saw me with the braids and she was so mad. And I can tell you right now, though, if you guys—
Hold on, Susan. Yeah, hold on, Susan. Why y'all do that to us? Why we do all this work, all this treatment, all this effort, years of training, and then y'all do me wrong?
Yes. And I know better. And you came and you said, that is not the scalp that I just injected. And I swear, it's almost as if I needed to hear that, because I went home that same night and I took them out. And I don't know if the camera can see it right here. See it?
Yep.
Right there.
Yep.
Lost my hair. There's the fringe. There's the part, and there's my hairline. That's a perfect show of traction alopecia. And people, it happened within 3 days. 3 days.
All my work.
So can you imagine? I'm sorry, Dr. K. So can you imagine? If I had said to myself, I just spent this amount of money on this hairstyle, I'm not going to take it out. If I had waited the 1 month that cornrow style would have lasted, it would keep pulling back. Oh, my area would be better. I had like, no way. I couldn't. Yeah. So, and I see my clients with this all the time. And, like say, for instance, I will get a text message from a client, one today who you referred, and she texted me and she said, oh, I'm patient Dr. Kindred. She recommended I see you. I want to get, this, and this done. And I say to her, we need to do a consultation, because I always tell people, because I'm a stylist who specializes in hair loss. I'm not going to do any trendy hairstyle. You're not going to tell me what style that you want. You can want the style, but I probably won't do it if I think that it's going to make your hair loss worse, right? I'm sounding like very hypocritical right now because I did the same thing to myself. but I'm just putting myself out there. But I'm not going to do it, and I will. And you will. I'll allow you to walk away. I'm going to try to convince you. Give yourself some time. Get your hair healthy first. It's not worth it, because when you recognize that you have hair loss, it is not a matter of how long your hair is anymore. It's about just having hair.
Yeah, we're not worried about the width. We want the fullness.
Mhm.
Absolutely. Absolutely. All right, next slide. So I'm going to talk about how I approach these different forms of hair loss, and so will Dr. Gainers. So I break it up into 3 to 4 different categories. And that's things that make your hair grow, right? Minoxidil, there's natural supplements and shampoos. So I'm like one of the only derms that firmly believe that once you start minoxidil, you are to never stop it. I prescribe it all the time, but not until after the patient is ready to stick with it forever. Whereas the nutraceuticals and the shampoos, I'm okay if they, fall off a little bit and then restart, because it's not as great of a loss. Let me pause and let Dr. Gainers talk about things that she does specifically for making the hair grow. Is it similar to this or different?
There's a lot of similarities, absolutely. Now, the caveat, I think, to the minoxidil is situations, again, where they are not constantly working against something, like something genetic. So I have had people who have had traction alopecia, for example, who respond to minoxidil, and it's really not lifelong, as long as they stop the hair pulling. If they are at that non-scarring alopecia phase where they have not yet lost the hair follicles and the minoxidil brings it back, then those people, I think, can get away with not using minoxidil forever.
You're absolutely right. Yes. Yeah.
But no, I love this list. I love this list. And of course you have cosmetic procedures that can be done, like PRP, things of that nature, LLLT, depending on what we're talking about. Mm-hmm.
Then there's what we call wellness. These are non-traditional things that they're not a medication, they're not a procedure, but they're still really important. And as you know, I'm the first derm to have a full service hair salon. Not the only derm, right? We have Dr. Gainers here. And it makes a huge difference in the example we already illustrated. We use devices for hair density checks. So we'll take photos, and Susan already emphasized, patients should take their own photos as well. However, we use measurements so that we can have objective numbers that tell us without bias if someone's improving or if they're not. So if it shows that they're not improving, that means we found out earlier they're worsening. So we know to step up our game before it's too late, or to tell us they're getting better. And the reason why we want to know that as soon as possible is because hair will fall out overnight and take forever to grow back in. So it's very easy to get impatient and switch the treatment regimen. Where if the density check shows that the patient is improving, then we know to be patient and to stay the course. And then every other month, we have a discussion group, a private one for our patients. And in March, I was at the American Academy of Dermatology. And at that time, it was a potpourri of topics where I just told patients all the things hair geeks were talking about when it came to hair loss. Dr. Gainers, I've just now decided I'm going to invite you to our July one.
Oh, right. I'm excited.
Yes. And then things that neutralize inflammation, specifically for inflammation. In my office, for CCCA, this is applicable in other cicatricial alopecias or other inflammatory alopecias. This is the most important category. More important than growing your hair is stopping the inflammation, putting the fire out. The most important category, the least liked category. And that's because you don't see a lot of difference with this. This doesn't directly make your hair grow. It's you removing damage, right? But think of it like this. If your house is on fire, yes, eventually you need to paint your walls and switch out your furniture. But the first thing you do is put the fire out. That's the most important thing to do. So that's why we use topicals, we do injections, we do pills for CCCA and other inflammatory disorders, whereas inflammation doesn't play as key of a role in the hormonal version, or if it's the non-inflammatory stage of traction alopecia. Dr. Gainers, what are some of the things you do to neutralize inflammation?
Can you repeat that?
What are some of the things you do for neutralizing inflammation in CCCA?
Oh, of course, steroids are going to be a staple. Antibiotics with anti-inflammatory potential are going to be a staple. Yeah, you have to do those things. Yeah. And I do want to say one thing, and maybe you can comment on your experience with this. I have thought about this when you were talking about hair density checks or comparing photos and all of that. There are some people, it doesn't happen often, but where as the physician and the patient, you should not panic if in the very beginning they actually look a little worse. You can get shedding with minoxidil. You can almost like shock loss from getting a hair transplantation right before it blooms. And it gets a little scary because you're like, should I keep going? Usually you got to keep going, and they will have their day when they blossom like a plant. But there is that scary moment in the beginning of treatment for a small handful of people where they come back and you're like, ooh, what just happened here? You know? But I don't know if you have a comment about that, but sometimes you just gotta keep going. You have to counsel people too about side effects of different procedures and hair shedding with minoxidil, things of that nature.
Absolutely great point. It gets worse before it gets better phase. However, I am spoiled because Susan keeps the patients on track. So once I had Susan, I often don't have to coach patients through because they're with her for 3 hours at a time. Right,
yeah, and Dr. Kate, can you talk about being a healthy person and eating right? And because unfortunately, I have a lot of my colleagues who are telling their clients, you know, get some blood work done, you know, eat healthy, you know, all that kind of stuff. Can you just explain that a little bit? And there's another question in the chat that I need to answer, but just talk a little bit about that for me, because I'm always fighting that battle. You know, I always compare two of my clients that I have, also two of your patients, yogi,
vegan
every day, and CCCA is just acting a fool. Then I have another client who just started presenting with some type of hair loss after my 20-something years of dealing with her. And, you know, that's because she's getting older, it's thinning, stuff like that, but hair down her back, full figured, eats anything she wants, whatever. Hair was just growing. So can you just talk about that?
Yes, so Susan's always trying to get me in trouble, but listen here, as physicians, yes, we want you to eat healthily, we want you to drink water, get plenty of sleep, exercise. We want that, right? Please do that. However, not everything crosses the path of diet, okay? So some people are told that they're not eating right or they need to do this or that. Imagine you came to me because you did not like the color of your eyes. No matter what you eat, it's not going to change the color of your eyes. Not everything crosses diet. So I have not seen diet and exercise change CCCA. What I have seen is stress dramatically worsen CCCA.
Yes.
So if stress is reduced for you by you exercising, right? That might be why you might think exercising does it or what have you, but it's more so stress than it is your diet. Because we definitely have people who have the worst diets ever and don't gain weight, right? So not absolutely everything crosses diet. We had a great question, and I'll get, I think one is for you, but the nutraceuticals, the question is, other than biotin, what nutraceuticals do you recommend? I want us all to answer this in unison. Does biotin work? Does biotin make hair grow? Yes or no?
No, ma'am.
No. Okay. No. And
Oh,
All three of us need biotin's publicists because they did a daggone good job.
you.
This myth
They
will
made
not
everybody believe.
die.
Telling you.
Biotin does not make hair grow. Now, it's a component of it, right? But think of it like this. It doesn't matter how many bananas you have. If you don't have a blender, you're not making a smoothie, right? So biotin is a component, but very few Americans are biotin deficient. So taking more biotin, you're just going to pee it right out. So I tend to, and this is indeed a conflict of interest because I'm a speaker for them and etc. But the one I recommend the most is Nutrafol, Nutrafol. There's others that work though. We also sell Viviscal Pro, Viviscal Pro. It has to be Pro. Lambdapil, Lambdapil. Lambdapil is the third one, and Inner Glow. And Inner Glow is the most affordable out of the four. Also works. I want to still make it balanced, but the one the majority of my patients use is Nutrafol. So to keep it balanced though, Dr. Gainers, what natural supplements do you recommend for your hair loss patients?
Yeah, Viviscal, Nutrafol, I think those are great. But again, that would not be the thing that I lean on if they have, for example, alopecia areata or CCCA. It depends on the type of hair loss. If they have, female pattern or something, maybe I could say, okay, you can try this by itself for a few months, but I tend to use it truly as a supplement to other treatments that we're doing. But
You
it
bring
does
up the point. Combination is the name of the game, right?
Yes, because they all have different mechanisms of action. So it tends to be you find better results the more things you're doing in unison. But yeah, if somebody had CCCA or something like that, I wouldn't tell them probably to just only do Nutrafol or Viviscal. Yeah, I think they definitely have their place.
Yeah, and from the stylist perspective, because good dermatologists who specialize in hair loss, hard to find. I'm telling you, waiting list is like a year or more, or whatever it is. So most of the times, if a client comes to me along with their wellness, because I'm in the office with Dr. Kindred and I see the benefits of Nutrafol, and I'm not paid, the benefits of Nutrafol. I see what it does for the client. So I will tell the client, listen, until your appointment with Dr. Kindred 3-6 months from now, buy the Nutrafol, get her healthy hair shampoo, come see me every 2 weeks, once a month. Let's get into a hair care routine. You would be surprised how much hair grows back in just doing that until you can see the dermatologist to get properly diagnosed. And I'm going to say that again, to see the dermatologist to get properly diagnosed. I hear stylists cannot diagnose. I trichologists cannot diagnose. Only a board certified dermatologist who specializes in hair loss can diagnose. So I'm telling you, as a stylist out there, be careful of the stylist that you go to. Most of us want to do good, but a lot of us ethically are not doing good because there's a lot of money in hair loss right now. And a lot of us are jumping on the bandwagon to get that money. So be careful and make sure you understand the only person who can diagnose you properly is a board certified dermatologist.
We're going to stop on that mic drop right there.
That was excellent, Ms. Peterkin. This is Karen again. I just have a quick question and a little bit of a programming note. It is 7:33. Thank you to everyone who is still on the call. We are going to go over just a bit, so thank you for hanging in there. But I don't want to interrupt too much this exceptional conversation. I did want to bring back one of the points that you made, Ms. Peterkin, about the hairstyles that we as Black and brown women tend to default to at this time of year because we're on vacation, because we're trying to work out a little bit more, or we're getting into the pool even. Mm-hmm. So you were talking about braids beforehand. What is a woman to do? If not individuals, what should she be doing to keep her hair as healthy as possible?
So I would say, this is how I tell my clients, right? If you take care of your hair through the whole year, right? And it's time, and you have hair loss, you're going to see the dermatologist, you're coming to see me, you're doing everything that you can. You are the client that I'm going to say, yes, while you're on vacation for those 7 days, you can get some loose, knotless braids, something not too tight, and you wear that for the time that you're on vacation, so you don't have to be, you can jump in the pool, do all that stuff. But you cannot wear the braids for months and months and months, because we now understand what a healthy, clean scalp does when you have hair loss. Dirty scalp makes hair loss worse, right? So your scalp must be cleansed. So you can get styled. So say for instance, you don't see the dermatologist for the whole year. You don't come to see me, but 2 months before summer gets started, you know that you're going on vacation. You're going to try to push everything in. No, take care of your hair, have a hair care regimen, and taking care of your hair doesn't mean that you have to come in to see me every 2 weeks or once a month. You check in, you maybe do a consultation like, Susan, I'm doing this. You know, you make sure you put your appointment with Dr. Gainers, Dr. Kindred, right? You do everything, especially if you've been diagnosed with hair loss. You drop the ball. You have to be on top of it all the time. So that's what I would recommend. Another thing that I recommend is, I know this is very hard for a lot of us to do, but I've done it. Before I found out that I had CCCA, I had long locks down to my butt, but for some reason, I didn't know then I was that sweet spot. My locks felt really heavy, it was pulling. So I cut my hair off, and it looked like it was doing better. With me, I started experimenting with, you know, natural herbs and oils. That's why I created my stuff, and it helped. It helped a little bit. But guess what? I had ended up having thyroid issues. And that's when I knew that something was wrong. My hair was dry and brittle. The whole top fell out because the thyroid made it worse, and it made the CCCA worse. And that's when I realized that, okay, something is going on. My thyroid issues made it worse, but something is still going on right up in the center of my scalp. And but because I had a very good hair care regimen, my CCCA never got to the point where I had a bald scalp. I always had hair. It was thinner. It was a little bit more brittle, but I always had hair. So your hair care regimen, and I can't stress it enough, your hair care regimen is so important. You can't just braid it up and put it under a wig. That's what most women are doing now. They're braiding it up, put it on their wig, and they keep braiding it. And so they have a spot over here, so they braid it and bring it to this side. Eventually, the spot is going to spread to here because you keep doing the same hairstyle. You keep doing the same parting to hide it. You have to change it up. You have to do things different. You just have to get to a point where, hey, maybe I just need to cut my hair short and start afresh. Sometimes your hair just need that relaxation. Another thing is that stress makes it worse. And one of the things that I see a lot with my clients is that they stress so much about their hair loss, that it just keeps getting worse. So a recommendation that I would do, I'm like, listen, why don't you cut it down? You still have it's still growing, it's thinner, but if you cut it down, you don't have to think about it. You get up and you go. That has caused so many of my clients here to grow back in, because they no longer have the, what do we call it? The George Jefferson look, where it's like thin and the sides are big. I cut it all the way down. It's nice and even, give you even a nice color. Rock your big earrings. You know, you have to, you have to jump ahead of it. You know what I mean? Like my clients, clients who have cancer, I will tell them, don't wait for your hair to fall off. You be proactive. You shave it down, and then let your hair, so that you can concentrate on the bigger pictures, which is getting rid of the cancer. So you're not stressing about your hair loss, and then you move forward when all your treatment is over. Then we can start, you know, doing what we need to do to grow your hair back. So it's just perspective, and you have to be real.
Thank you for that. Thanks very much. Do we have any other questions on this point of treatment, or should we proceed?
Looks like we can keep going.
Alrighty.
And so we just want to touch on some of the things that Dr. Gainers and I offer. It's pretty cutting edge, and I feel like we as Black and Brown patients, we deserve cutting edge stuff too. And it's the reason why the center is so important, why research is so important. A lot of times these things aren't done with us in mind, and so you need forward-thinking dermatologists like Dr. Gainers and I to do so. So I call it repair, and that's where we're trying to take those damaged follicles and fix them. We do a deep hydrodermabrasion, we suction the gunk out and squirt in growth factors. Growth factors heal the skin. When you touch yourself, it heals because of growth factors. We use your own blood and take growth factors out of your platelets. We use small vesicles. There's even stem cells that are available. There's a lot we can do that actually repairs the damage that's been done. That's the new furniture, painting your walls and remodeling your house after a fight. That's repairing after we've gotten the inflammation under control. I'll let Dr. Gainers talk about hair transplantation. We do a lot to save hair loss. We only do hair transplantation maybe every 1 or 2 months. But Dr. Gainers, I believe, does it a bit more often. You want to talk about hair transplantation, Dr. Gainers?
Yeah, so
Overview.
Patient is interesting. It can be very effective, but it has to be the right candidate. And I know how you feel, Dr. Kindred, about biopsies. I try to plant the seed because you never know if a patient's coming back. You never know what the situation may be. I always plant the seed that before you move forward with the hair transplantation, have someone do a biopsy. What you don't want is to go through with the surgery, an expensive surgery, and then your grafts don't take and you have a poor outcome because you think you're treating traction alopecia, but you're treating lichen planopilaris or some inflammatory condition. With women, usually it depends on the type of hair loss, but a lot of times women thrive without hair transplantation, or they have a type of hair loss that that's probably not going to be your go-to in the very beginning. And even women with female pattern hair loss, because it's so diffuse, getting a good donor can be an issue. So I still find hair transplantation is going to be much more popular with men with hair loss, especially men who have male pattern balding and a good donor supply in the back of their scalp. That's going to be where you'll find you're going to do a lot of hair transplantation. But with women, I would say the minority of women, that would be the go-to, unless, again, you're just dealing with pure traction alopecia and they are in the scarring phase of it where it's not going to come back. Then I think it's a wonderful treatment for women in that situation.
And then the three of us trained on scalp micropigmentation together. Susan, you're the one that does it in my office. You want to give an overview of that before we wrap up?
Yes. So I did, quite a few, and the one that I feel that it really worked really well is for the picture that you showed with the traction alopecia, where you have the 3 lines. It really filled that in, especially if it started, scarring and it's not going to grow back. It really filled it in really well. And if you have, your hairline is kind of a little bit thinner from female pattern baldness, stuff like that, it fills that in. So those are the places that I think it works really, really well. I have one client who wears her hair in a mohawk because that's a hairstyle we created, because, she has the thinness of going back most of the sides. So I did the scalp micropigmentation, shaved her side down, and unless you come up on her and exactly what's going on, you just think that, oh, she's just rocking that style. She's just wearing a bald with her mohawk, and we color it a nice bright color, and that's how she rocks it. So it all depends.
Excellent. Okay, Ms. Parker, we could pause here and just do a check. Yeah, and we can pass the slide up. And yes, we talked about the top 3 forms of hair loss in Black and Brown patients. What would you like us to do next, Ms. Parker? I know we went over a little bit.
No, it's
Yeah.
totally fine. I think that there was probably one slide left, or is this the last one from your presentation? Can we move forward, Kristen? Yes.
Okay, so this is a current client of mine, and she has CCCA. As a matter of fact, her hair has grown back even more since then, because this picture was a while back. And she comes every 3 weeks. She goes in and she sees Dr. Kindred, I think like once a month for her shots and other treatments that she's getting done. And we've seen significant improvement, and this is our go-to style. And I gave her permission, like if she's going out, I was trying to find the photo, but I couldn't, where she's going, if she's going out, she puts like a little bun on top of it. But I gave very specific instruction. As soon as you get home, even before that, once you hit the car and you're on your way home, taking those pins out, it's not worth it. But for just that few hours that you're out, you're partying, you can wear a bun, but take it out. And she listens, and she's on top of her treatment, and she understands what's going on. And I always take her camera and say, let's take your photo today. And she dates it so we can track her progress. I have a photo, she has a photo. I mean, so it has to be, you know, a good, like almost like a nice tango in between, you know, everybody, you know, the sway, the dancing, everything flows, you know, and things will happen. I've been in the salon with a patient that Dr. Kindred literally saw like a week before, because she waved to me as she was passing. She's going to get her treatment. And then she came in the following week to see me to get her hair done. And there's no, I mean, I was like, what happened? And she's like, yeah, I was wondering. I just stopped everything and I pushed my head outside the door and I'm like, Dr. K, emergency.
Yeah.
And she
Yes.
took her right away and gave her some different type of treatment. We ended up, her hair was literally, I used to do flat twists just like this. We literally ended up cutting her hair very, very short. She's wearing a short fro right now. I gave her some color and I'm like, hey, this is it. Your hair can't do any more manipulation. Your hair is just saying, this is it. This is all I can do. This is where we are. And we just have to come up with a different hairstyle and a hair care regimen. So this is the reason why it's important that you see someone regularly, that you see a stylist who's going to be so invested. Like I actually don't like to use the word hairstylist, but of course it is what it is, because I don't consider myself a hairstylist, right? I consider myself a hair care professional, you know, because if someone said, my clients know now, they will say, do you see anyone who doesn't have hair loss? I said, not particularly, because I don't do trends. I don't trend the hairstyle. I don't use a whole bunch of gel. So if they're going to come to me and stress me and ask me for all the different hairstyles, when I have clients with hair loss who need my help, I'm just not going to do it. After 40 years, that's not where my headspace is. My headspace is to help women and men who have hair loss. So that's why I keep on stressing a good hair care regimen. You can't just braid your hair and put it under a wig and say, oh, I'm natural. Yeah, you're natural, but you're not taking care of it. So it will make your hair loss worse.
But isn't that a protective hairstyle, Susan?
Protecting what? What is protected? That's the next thing. What are you protecting? There's nothing that's being protected. As a matter of fact, let's just dish it out right here. Let's just like spill the tea, right? When you braid your hair, you're actually stifling it. You're making it drier because you're putting this hair extension that has all kind of chemicals in it, right? You don't know your reaction to the chemicals. Honestly, we really don't, right? We don't know the reaction to our skin or scalp has to the chemical. Why do you think that when you take your hair out of braids, it's so dry? Number one, moisture is water. Your hair, your scalp hasn't seen water in weeks or months. So of course it's gonna be dry. What happens to our skin if we don't take a shower or splash some water on it and then we don't put some lotion to retain that moisture? It's dry. So the same thing happened to your hair. So that's the reason why when you take your braids out, it's so dry, and then you try to brush it, without wetting it down with some detangler before you start brushing, it's dry, it's brittle, it's gonna break. So you can't be protecting anything. As a matter of fact, the flat twist hairstyle right here is more of a protective style than actual hair extensions.
I'm going to have to coin a new phrase, the gospel according to Susan, because that piece of information there, because you're right. What we are told when we're not speaking to healthy hair care professionals is that putting our hair up and away is quote unquote protecting it from whatever other elements there may be out there, including moisture.
Mhm.
And to hear that it's the polar opposite is, I think, really going to wake some people up.
Yeah.
So thank you for that.
No problem. I wanted to include this particular hair because when I was looking for some photos, this patient and client of mine, the patient, Dr. Kindred, has CCCA. Do you see the red information from the CCCA? I wanted you to see it. You see it in the back, you see it in the front, you know what I mean? You know, and as a matter of fact, I think she probably got treatment the same day. Usually that's what happens. But what we do is we, she's another one who I tell, you know, she actually made this bun herself, twisted it, very genius. I learned this from her actually. And we put it on very loose and, you know, she will wear it out, but at night she takes it off and she'll put her topical on and, you know, and go about her business. But she's been fighting her CCCA for years and, you know, she's not giving up and we're not going to give up.
Yeah, she's one of our toughest CCCA patients, but we're able to keep her out of a wig.
Mm-hmm. Yeah.
All right. Is there
Beautiful.
another slide or are we able to wrap up?
I think we can wrap up at this point. I just have,
yes, it is.
it is. First of all, ladies, I'm so appreciative of the extra time that you spent with us this evening. I'm going to ask our listeners who are still on, if you have any other questions for Dr. Gainers or Dr. Kindred or Ms. Peterkin in particular, you can reach out to them. We will, in the follow-up email, we will send all contact information as well as sort of condense some of these fabulous tips that they've shared with us this evening. And what you're seeing in front of you right now is a special presentation we've had with one of our other presenters that we've had on the roundtable a few times on Monday, not the 26th, but this coming Monday, Juneteenth Monday. We have been invited, I'm saying we like it's the royal we, I have been invited to co-host the Excuse Me Doctor show with Dr. Melissa Clark. So it's a great honor for me and for the Community Wellness Roundtable team. We will be speaking on Monday evening at 8 p.m. EST, not the 26th, but Monday, Juneteenth, with Dr. Melissa Clark and a couple of specialists about Alzheimer's, the whys and the hows and what to do's. So please do join us. We will send out the information. And again, thank you to our very special guest this evening, Ms. Peterkin, Dr. Gainers, Dr. Kindred. Thank you so much. As you close out of this presentation this evening, there will be a very short survey. So we ask that you please fill that out. Thanks very much. Do enjoy your walk and have a safe summer. Take good care.
Thank you.